is Dr. Kavitha Krishnan. I am the founder and pediatric occupational therapist at Healing Synergy, which is a pediatric therapy clinic based in North Carolina. Healing Synergy specializes in occupational, physical, and feeding therapy for children with sensory issues, special needs, and feeding difficulties. What we do is we customize home programs to meet your child's needs, strengths, and the treatment goals. Should you have any issues or if you would like to inquire, please reach us through our contact page at healingsynergyllc.com. We look forward to hearing from you. Thank you. Hi there. This podcast series is here to help guide us, act as a guide for parents of children with sensory needs, special needs, with practical and real life tips and strategies that you can implement at home. As always, myself and my team of staff are here to help you and be available as assistants for you should you have any questions. So please don't hesitate to leave your questions, your comments below so that we can help address them. I'm so excited that you're here today, and so let's jump in today's episode. Today we have Dr. Sherry Stancliff, who is full-time faculty with Rowan Cabarrus, who's going to be talking to us about school-based therapy. Dr. Stancliff, could you tell us a little bit about yourself?
Dr. Krishnan, I'm happy to be here. I have a wide variety of experiences. Have been practicing as an occupational therapist for 37 years. I did my first 17 in adults and worked at Forsyth Hospital. And then as my kids got older, I decided, hey, I want to be able to go to their sporting events and not have a 365-day-a-year coverage demand of the acute care hospital. So I switched to school-based. I worked in Winston-Salem Forsyth County Schools for 15 years as a school-based OT, and I did from preschool to high school while I was there. And then in 2017, 2018, I went back to school and got my doctorate and transitioned into academia at Rowan Cabarrus Community College, where I'm full-time faculty. And in between there, I also achieved the Occupational Therapy, American Occupational Therapy Association specialty certificate in school-based practice. So that kind of adds a little more expertise into my resume that allows me to be here today.
Yeah, thank you. Working with our children, especially from early intervention onwards, just preschool, that's a huge transition. And then, we also have kids going through from preschool onwards, and it's just the demands are a little bit different. And if you could talk to us a little bit about what the difference would be, like from transitioning from early intervention and then into preschool, and what parents should expect.
So preschool is a great place to begin lots of different skills, right? Number one is play. And then that interaction with peers, a little more so than like early intervention, but into preschool, it becomes peer play, peer socialization, and then following routines and learning how to kind of do some simple following routines and following directions. And we begin to form an attention span for sitting in either at a table with a teacher or in a group with our peers and doing a game.
Are there certain requirements that you think parents should have their kids start doing before they get into preschool?
That's interesting. I hadn't thought about it because each home environment is very different. So the expectations can be different than a classroom. So maybe just really thinking about a classroom environment where the teacher is responsible for anywhere from 5 to 10 children with an assistant. And that requires some following of rules, simple rules that allow the classroom to function as far as sitting, following the routines, going in and out of the bathroom, washing our hands, taking care of our backpack and our coat, taking our coat off. They get assistance as they need it, but beginning to develop some of those independent occupations as far as that are needed in a school-based as they transition into kindergarten. So we started in preschool as far as beginning to manage their own tools and manage their own pieces of their as a child.
What would you say would be red flags for children that parents should probably pay attention to and see that, maybe they need to get an OT eval done?
So I think if within that naturally occurring preschool environment, if the child is beginning to struggle with any of the motor demands related to occupation, whether it's holding a crayon, beginning to use scissors. But remember, at 3, those are developmental skills. But by the time I get through preschool, I should be able to do some of those skills, not as an artist, but proficiently. Like I should be able to mostly stay on the line when I'm cutting a shape that's mostly lines because curves are harder. I should be able to color within lines, but not be the 5th grade artist that can create this artwork of all different colors, right? So it is knowing what's accepted and what's not. And the other thing is I'm coloring larger shapes, not small, intricate shapes. But I'm also able to follow directions. I'm able to sustain my attention for about the age, right? So if I'm 4, about 4 minutes. If I'm 5, about 5 minutes, and stay on task for that amount of time.
So you did touch upon pre-writing skills, scissor skills, also activities of daily living, like putting on basic things like your shirt, your jacket, putting on your shoes, socks. And also you talked about play. What are some of the things that parents should look out for in play in preschool?
So in preschool, peers, they should begin to start to play together in like a center. So be able to play with trucks together and share and maybe create a common racing theme or a racing track, or go into the daily living center and kind of pretend play family. I know a lot of times in my preschool classes, this is where we would sit down and the teacher and I would become the connoisseurs of the diet created in the kitchen environment, right? So you begin to pretend to play, you play together. You can play either side by side or together with a common theme.
Just to give insight to parents, so would you be in the classroom with the teacher, or would you be removing the child from the class?
Good question. So school-based, we always want to be in the environment where things happen. And in school-based, it happens in the classroom a lot of the times, or it happens in a cafeteria, or it happens on the playground. So I pushed into those environmental routines depending on what the child needed. If I was working on fine motor, I would go during art time. If I was working on those self-care skills, I would go when they came in the door, because that's when all that naturally occurred, taking off the coat, putting up the backpack, unpacking the backpack. If we were working on kind of more independent toileting, pulling pants up and down, creating a routine, washing hands, then I would try to hit that toileting time, because most of my classrooms had routines of how those things were going to happen.
And should a parent think that they needed an OT, after listening to this episode, how should they go about getting or accessing a school-based OT? So
if a parent is concerned about development, then they would go through their preschool intake of their county. And that's the team that usually assesses the needs of our preschoolers before they hit kindergarten. And that is a multidisciplinary team. But ultimately, that team also has to identify educational goals where the student is lacking. And then occupational therapy is still a related service. So we can't serve a child individually in isolation for just occupational therapy or just physical therapy in a school-based environment. It is very much a team approach, and education is at the top of that pyramid. So the student has to have an educational need that then also lends itself to needing those related services to support that child to gain those educational skills.
I usually get this question. So what's the difference between having OT services or occupational therapy services outside of school and school-based therapy services? What might be the main differences?
So one main difference is the medical model and physician-driven. So outpatient clinics generally are physician-driven based on more of a developmental model or a lack of skills. And the educational model is a lack of skills, but it's a lack of skills within the educational environment, and it's determined by educational standards for each age, very similarly, but at the top of that pyramid is the need to have educational skills, whether that's kind of some of those skills we talked about, being able to attend a class, being able to manage their own self-care occupational environmental tools like a backpack and a jacket and pulling pants up and down, or whether it's the motor skills to access the educational environment and be able to do appropriate 3-year-old and 4-year-old art projects.
So that's actually really good to know. The main difference is what they need to look out for, because sometimes parents do ask, like, should I have outside OT services? When would it be like a good time to combine two services, really, the outpatient and also school-based services? So you did talk about they have to go through the intake process for them to be accepted, and then it's like a multi or transdisciplinary approach that you have. So Dr. Stancliff, going back to the question of a parent thinking that they want their child to be served, and now it's deemed that the child can get services, what happens next, and what laws govern that?
So I think it's real important here to kind of let parents know that the law that you're working within is called the Individual with Disabilities Education Improvement Act, or IDEA 2004. And it's been revised a couple times, which branched out and included, in its latest revisions, it included both. First revision included preschool. The second revision included infant toddler. So your infant toddler program. But with that, the schools then interpret like, okay, so you're saying you're concerned about some of the things that you're seeing with your student, and they've been getting early intervention. So you would go to that school-based preschool team. And the first thing that has to happen is you have to remember that just like you had an individual education family plan, the school-based team is going to look at doing an individual educational program. And that's going to include the educational team. Just like your early intervention plan probably included your whole family or the family team with your therapist.
Right.
Okay. So then what happens is we have to decide if that student has a deficit in an educational area. And if they do, then they will qualify for special ed first. And that they have to answer those questions about whether they have a disability that's not allowing them to access their educational environment. That has to be answered before anything else can be on the table when you're talking school-based. So it has to impact education. It can't be that it just impacts home life. And that's really hard to understand, but that is the way the law is written, because it's all about education at this point. And special ed has to be on board first before we can add what they call related services. Related services are those services that will support that special ed teacher and that child. And that's your OT, PT, speech. It can be rec therapy. There's audiology. There's all kinds of individuals that fall under that related service. But the first decision is, does the child need that education extra program? And with that, we also have to look at least restrictive environment.
Right.
So when we're talking least restrictive environment, we want children to be with their peers because they learn a lot with their peers. Peers are better influences than teachers or adults ever. And we always want that student to be included with their peers as much as possible. And those services of each related service should happen in that environment. When we pull children out, like into a clinic or into a separate setting, then we're restricting them and we're restricting their access to their peers. And that's important. You'll hear that. So with that in mind, we also have to consider that in a school-based setting, that child might receive special ed first and see if just a little bit of different instruction will allow them to access their environment before we add related service. Because with each service, we're restricting that child's access to peers and their regular educational program.
So who would be the first professional who comes to see them to determine?
So usually preschool is a team approach. With autism, we're generally using the transdisciplinary play assessment. Okay. That's done in a team environment. And they actually have these conversations. They have a facilitator who facilitates with the child, and the rest of the disciplines are part of assessing what they see going on during the play. And then they will all write up their reports and then meet with the parent and have a discussion about what the assessment included and what they saw, what they felt would be the results, and whether those results would include meeting the questions of the child having a disability or pieces of his disability are impacting that access to education.
And the transdisciplinary play assessment you talk about, is that just for children with autism?
I think that's where it's used quite a bit, but they're using it more and more throughout the preschool area because it's got good research.
Okay, so that's one thing the parents would know. If they see it, they would know that's the assessment that was done. And if a child came in without a diagnosis but showed the signs, the red flags for a child with autism, what happens then?
So most of the time the schools are going to send them back to their physician for a diagnosis. Okay. Schools aren't going to diagnose. Now we have tests that the psychologist can give tests that would possibly indicate that they have signs and symptoms of autism, but in general, the school will not diagnose a child with autism. There is a worksheet for each disability. There's 14 disabling categories that a child may present with and receive services, and they're going to have the IEP team will kind of look at each one of the 14 and decide which one the child meets the criteria for. Autism has to have the sensory component, the communication component, and the motor skills component. And sometimes probably the more likely diagnosis is just developmentally delayed. And this can hold a lot of different diagnoses as we're trying maybe to look at a 3-year-old and we're not quite sure what we're seeing. You want to be really careful about what kind of category you're putting a child in. So developmental delay is one that will allow the team to serve the child and kind of see how they grow and see how they respond to the interventions that are given in the school system.
And evaluations are done. So it starts off seeing if they need other support services, and that's when it kind of expands the number of services and evaluations that they get. Is that correct?
So they have to qualify for special ed first. So it's an educational piece. Usually the lens is more educational first. And then as the team sits down with the parent and there's concerns, then they'll bring in other related services to do their assessments. Probably one of the other biggest differences between an outpatient clinic and school-based is that in the outpatient clinic, the occupational therapist is going to have looked at their assessments and determine need, and then send that to either the insurance provider and the physician to get that order and get it approved. In school-based, the decision is always left to the IEP team. And the parent is part of that IEP team, but ultimately the team decides if the student is going to receive related services and how often that related service will come in. It is not left to the OT practitioner to decide.
There's a team approach, even with the frequency and the amount of times. Okay, that's actually really helpful. And do you know roughly what the frequency usually is and the duration of time?
So it's always individual, and those times have been changing in the last couple of years. So I'm gonna stay away from that question because I'm not sure, like today's practice, what that would look like. They do serve, like generally it's weekly or monthly, and it's generally they're going to decide how many times a reporting period, and the reporting period is 9 weeks. And that's decided at the IEP meeting, and so the parent will know. They also they will say whether or not they're going to be in the special ed classroom or whether they're in the regular ed classroom. Because when we're in the regular ed classroom, we're not pulling that child out. So we're not restricting their environment. And that's important. But ultimately, we want to be seen, like I said earlier, we want to see that child in the environment where the skill deficit is taking place. So if it's struggling to have those social conversations in the cafeteria with my peers, then we want to be there. If it's coordination and motor and I'm trying to play with my friends, then I want to be either on the playground or during specials and center time in a preschool classroom. Or if it's those fine motor skills, then I'm going to be at art time. And a lot of times there's other centers that are developmentally appropriate that work for children who have sensory differences, because there's like a sensory center, or there's a time where I had one teacher who liked to keep her sandbox full of different things. So during Easter, it was Easter egg grass that she would hide stuff in, right? And then other times it would be kinetic sand. And then as we got towards May, it was water. So it was a perfect time for an occupational therapist to show up.
Oh, that is awesome. And thank you for making that difference clear about the frequency, because, in outpatient practice, it's usually like 60 minutes or 45 or half an hour, depending. But that's really different from a school setting, what the duration of time is and the number of services. Are the reevaluations done yearly for IEP purposes?
So school-based is every 3 years.
Okay.
And it's mandated at that 3-year renewal, they can decide what pieces they need new information. And again, the child's education is at the center of what else do we need to help Johnny access his educational environment. Okay. Like, do we need a new educational? Do we need a new psychological? Do we need a new occupational therapy assessment motor or a new physical therapy motor? All of those are decided at the IEP team at that annual. And it's done at least every 3 years. It can be done more frequently if there's a change or a concern. And it can even be more of a record review at 3 years, and they can elect not to look for any more testing, feeling like it wouldn't give them any more information to serve the child.
Okay.
Usually if that happens at year 6, if you don't test at 3, at year 6, you would have to do new testing.
At year 6. Okay. So that goes on for a broad range of time.
It's a much larger range.
And like adaptations that the child needs, that comes through the IEP meeting, and that would be provided in the classroom.
Yes. So the IEP is going to include the frequency and duration and the amount of time that the child is going to be removed from their regular peers. And that time includes the special education from the teacher and then related services. And those goals are usually, that's kind of another difference, where the goals are team goals. And like the teacher and the OT practitioner might be working on a very similar skill, especially when we're in areas like fine motor, or we're in even areas of following directions and attention, because the teacher needs that too. And the teacher's in that classroom 24/7, and the OT practitioner is making visits dependent on the IEP time, but they're not in there all the time.
Right.
So a lot of times we share goals, which is a little different than the clinic, because in a clinic, you don't share goals. You have your goals and you're collecting your data in an outpatient clinic to meet those goals. But the progress for those goals, the parent receives progress every quarter.
Right.
And the teacher and occupational practitioner or speech therapist will always collaborate on that progress and collecting data.
And the data collection is done across the board, right? The teacher is doing it, the OT is doing it, the PT. So every discipline is actually collecting.
Every discipline should be doing it. Yes.
Okay. And is that shared with but that's shared during the IEP meetings or the quarterly meetings with the
Yes.
families?
Yes. Okay. And the progress. So the IEP goal will, at the next year, will have a statement that essentially allows the parent to know what the student is doing and what they still need to do.
Okay.
Called the level of performance. So where they are.
Okay. And that's done quarterly. So that's actually really good.
So the level of performance is done yearly. The progress, though, is done quarterly.
Okay. Got that. There's just so many different pieces.
It's its whole language. Like when I transitioned to school-based, I was like, okay, I have to learn a whole new language.
Right. Even being an OT, this is so intricate, the different pieces. It's a completely different world out there. Do these school OTs appreciate having links with OTs in outpatient clinic, knowing what they are doing?
So I think that speaks to where we have to be collaborative as a profession, but we also, parents have to realize that we can't talk to each other unless they give us permission.
Thanks, Sherry, for making that, clarifying that difference. So what are the OT services that a parent can expect?
So, we can provide direct services to the student, but obviously we also have to consult with that teacher. We have to do a lot of discussion and collaboration with the teachers so that whatever we decide, we're both doing for that child, because consistency is paramount to the child making progress. The other thing is that we can recommend adaptions in the environment, adaptions to educational materials, assistive technology tools. And remember, assistive technology is a gamut, right? There's what we call low technology, which can look like a pencil gripper, and high technology, right, which can look like voice to text on Google if we're trying to look at writing. And we might recommend to the parent a certain type of jacket that doesn't require the fine motor skills that like that fastening zipper recommends. And here's a great example of maybe a skill that you would work on in an outpatient clinic that a school OT probably will not work on, and that's shoe tying.
Right.
It requires visual motor. It requires a lot of executive function, recalling the sequence for how to manipulate two strings that look the same. So it's got a lot of skills embedded in one skill. But the problem is that if a child can't tie a shoe, it doesn't impact his ability to participate in his educational environment and read, write, do math. He might trip. He might trip. But the flip side is that there's shoes out there that are Velcro or slip on, which in today's world are typical and appropriate.
Right. And you made that clarification. I mean, that's great clarification because that doesn't affect their academic skills. So that's not something that they can work on in school.
Right.
Because we used to get lots of those kids coming in for
Yeah.
tying shoelaces.
Right. And at the same point, sensory differences, if the child can manage them, my daughter wouldn't wear a turtleneck, still doesn't wear a turtleneck, didn't eat peanut butter and jelly, but would eat peanut butter sandwiches, would eat meat sandwiches, no condiments. So essentially it was 2 pieces of bread with a piece of turkey thrown in the middle. So she had sensory differences, but they didn't impact her education. She was still able to participate in her educational environment. And mom created lunches and clothing that worked for her, right?
Right.
So she had OT, outpatient, I guess you could say. It was in the house. But she didn't need it for accessing her education. Now, later on, she had a learning disability that impacted, but she didn't need OT.
Okay.
So we can provide a gamut of skills as the school OT or the school OT practitioner, because we do use our occupational therapy assistants also in schools. So we use both the occupational therapist who's in charge of your assessment and working with the IEP team. And then you have the occupational therapy assistant who might be doing a lot of those interventions and collecting that data for us.
Okay, awesome. That's great. Do you think this is a good time to talk about the difference between what IEP is and what a 504 plan is?
Yes. So remember at the beginning, we said that it was the American Education Act that we work under. I'm looking for my resource and I flipped it way too far. Okay. So school-based is working with the Individuals with Disabilities Educational Improvement Act that has been revised several times. If we're talking about like 504, now we're switching to something different because the Education Improvement Act really looks at the child's ability to complete education and needing more supports. And they now use a pyramid. It's called response to intervention when we're dealing with special ed in kindergarten, like kindergarten on up through, not really in preschool as much, but in kindergarten and up. And we have a pyramid, and at the bottom of the pyramid, let's say a child's having trouble with spelling, then the teacher is going to implement some interventions with that child one-on-one and see if they can get that child to catch up to his peers.
Okay.
If it works, they don't go to the next level in the pyramid. If it doesn't work, then the next level is they go to the school improvement team and they seek a little more collaboration with their peers. Again, they do intervention, collect data, and if it works, that's where it stops. At the top of that pyramid is the special education. And we don't want to be, that special education should be 10 to 15% of our population in a school base across the county. So you don't want it to be, if it's too high up there, then we're not doing something at the bottom right.
I see.
And with that, that's where this Improvement Act comes in, and we're part of that top pyramid. Now, with some expansions of the role of a school-based occupational therapist and practitioner, they're beginning to understand that we can be kind of like, if the bottom of the pyramid is handwriting, then why not call in the motor specialist to help with those bottom interventions and collaborate with the teacher? It's not special ed, it's collaboration with the teacher. And then see if that works. Before we go all out, remember, because the top of that pyramid is that restrictive environment. So we're trying to prevent that. So that's the whole education piece. And that serves children from 3 to 22. Now, after that, what happens? So the American with Disabilities Act that has traditionally looked at access. We remember initially it was changing buildings, so we had handicap parking spaces that were in the right place, right? So they could access the actual building and ramps and that kind of thing. Well, it also looks at the ability to access job skills and discrimination and those kind of pieces. So what happens is children or individuals who have a disability then at 22 kind of switch from one law to the second law, which is the American with Disabilities Act. And with this comes not specialized instruction, but appropriate modifications to be able to access their environment, which might be a school if they go to college. Mm-hmm. So this looks very different. It's called a 504, and a child can have a 504 and an IEP program, or they can have one or the other. But when you're 22, your IEP doesn't go to college with you. You don't get specialized instruction into college. You go to the American Disabilities and things like a copy of a classmate's notes, recording lectures, extended time, read aloud for a test, having a test read aloud to you, or getting books on tape or auditory books. All those are things that you can put into a 504 that a university and or college system can provide to a student with disabilities. Both of my children had IEPs, and then we were able to change them with testing done their junior year of high school, and they took 504s to college. They were a little different. Things like copy of notes, auditory textbooks, and then extended time were important to my kids' success in college. And both of them graduated. Both of them were honored students and graduated. So they did really well. But, that was, usually we toured campuses, and then we went to student services to find the person who was part of the student disabilities on college campuses. But that's that 504.
And so that is something that would be important for parents to know, that they should seek out the council that you just talked about, right? For the Disabilities Act.
Yes. So student services, there's going to be somebody who's in charge of student disabilities. And that's also part of the IEP team should be talking about that at 12, 14, and 15, they start talking about transition, and that's a big transition. So that's kind of where the parent can have some of those conversations about, so what am I going to need to look for in a university? What, because even things that you don't think about, the size of the campus, the accessibility of the campus, the amount of students in a class, like those are all things that are really important for a student who has a disability, for a parent to be thinking about, and how that's going to translate into your child being successful. Some of the hardest classes for individuals with disabilities that are kind of the ones you don't see. So you look at that person and don't know they have a disability, right, are in the larger universities with 150 students sitting in a hall to take that gen ed history or that gen ed English. Right. And making decisions about using alternatives like a community college to get some of those classes, or even just to experience college and see what's going to work and what's not. I mean, you want to set your child up for success. And it's interesting because I ended up myself going to a community college for many different reasons. And I like the small classroom size. And now that I'm teaching there, I kind of have reconnected with, it's a great place to start college, to find out what's going to work and what's not going to work. Sorry, I plugged community colleges, but I had to.
No, not at all. But that makes total sense because it's also more personable for the child, right? With the instructor. Yep. And just like you mentioned, that 150 students, it's hard for the instructor and for the student themselves. I really appreciate the fact that you also mentioned at 12, 14, and 15 or 16 that during the IEP sessions, they mentioned about this transition into college. Yep. At least it starts the parents to think what to expect as well.
Yep.
So that's actually really useful. I want to go back into the least restrictive environment that you talked about. So when when do they determine when to place the kids in the least restrictive environment versus a class with peers with similar sort of disabilities?
That is mandated by law that the child should be placed in the least restricted environment, which would mean in his peers. So the IEP team really has to consider lots of different things. Let's stop for a minute.